طيب حدا قرأ على البي ان تي؟
bone marrow transplant.
حدا بيعرف ايش يعني البي ان تي؟
معلومات
بون مارو ترانسبلانتيشن اخر
بس
شيء
يعني بون مارو ترانسبلانت. طيب وين نستخدم البون مارو ترانسبلانت؟
aplastic
بلاستيك انيميا
حدا
aplastic
قرأ على البون مارو ترانسبلانت؟ طيب انا اسمي دكتور عدنان سعد، طبيب اورام، medical oncology and bone marrow transplant. Does anybody read anything about bone marrow transplant? Any kind of transplant? Anything about transplant? تعرفوا على transplant? Somebody say something.
زلمة اسكت مستر.
Okay, how many types of transplant do you know?
4
واحد يرفع ايده. Somebody. Go ahead.
4
How many types? احكي لنا اياهم in general.
4
We have solid organ transplant. Okay.
لا انا
We have hematopoietic stem cell transplant. Bone marrow
انت قصدك
transplant.
عن
Two types
الانسان
of
لانسان
transplant.
اوكي
Solid organ transplant. What kinds of solid organ transplant?
liver
Liver.
kidney
Liver,
Heart.
transplant, heart transplant, lung transplant, skin.
skin
Okay. How many types of bone marrow transplant? According to the what you mean by how many types of bone marrow transplant, according to the donor and according
linked
to
to the receptors.
what kind of chemotherapy you are giving. In general, medical oncology deals with what's medical oncology? What's oncology?
Study of malignancy.
malignancy
Science
of
of
malignancy
cancer.
cancer
Okay, oncology is science of cancer. Bone marrow transplant is a section of medical oncology. It deals with hematopoietic stem cell transplant. Where is the stem cell origin? Where it resides? Stem cells
the bone marrow
in the bone marrow. Yes.
mesothelium
So stem cells are in the bone marrow. Do we have stem cells in the peripheral blood?
yes
Yes. Yes, we do.
yes
Okay, so how many types of bone marrow transplant? According to the donor, we have autologous
هذول اللي بدي
transplant.
أحكيه.
That means
from
The same person.
person is the donor.
is the donor to himself
And
Allogeneic.
allogeneic transplant, which means
Twin.
stem cells taken from another
Isaac.
donor. And we have many types of other donors. We have full matched sibling donors. We have unrelated matched donors. And we have cord stem cells. And we have the what? Syngeneic. What does syngeneic mean? Identical twin donors. Okay. And according to what kind of chemotherapy we are giving, we have high dose chemotherapy and we have reduced intensity chemotherapy transplant. Okay. When did it start? It started in 1994. It was by chance, like most of the science findings, by chance. Actually, they found that after Hiroshima bombing, they noticed that people who were exposed to the atomic bomb, they got their bone depleted from all kinds of cells. And they didn't know what to do for them. So they were thinking of transfusing blood or bone marrow for those patients to survive. And they noticed that when you expose a mouse just cover the spleen, they noticed that the bone marrow starts dividing and getting new cells. So it's very simple. By chance, they discovered that if you cover an organ that is rich with stem cells and you expose this person or this body to the high-dose chemotherapy or high-dose radiation therapy, you ablate the whole bone marrow and it restarts if there is still stem cells in the body. That was the beginning. Okay, and then they started trying many types of transplants for curing diseases. And they had some success stories. In 1968, a person whose name is Gatti, he started the first successful allogeneic transplant in a patient with a benign condition, not in a malignant condition. And successfully, and the patient died later on. Okay. Later on, they discovered that the HLA system, you know what's the HLA system?
HLA.
What's the HLA system?
Leukocyte
Human
antigen.
lymphocyte antigen. And they found that getting stem cells from a donor that has the same HLA system, matched donor, gives a better quality of transplant, and the patient survived. So they started looking deep into the HLA system, and then they started in 1977 Seattle. They were the first who really started the transplant program, and they were successful in treating leukemia with allogeneic transplant. Then they started an unrelated donor. First, they started with the related donors with full matched HLA system, and then they started the unrelated matched donors, and they were successful with some more complications due to chronic or acute graft versus host disease. You know what's graft versus host disease?
Yeah. اسحب.
Okay, graft versus host disease, the immune system attacks the new cells, and it attacks its own body cells. This is the general idea of graft versus host disease. Okay, they were using stem cells from the bone marrow. Later on, they discovered that they can use peripheral blood stem cells. They started using granulocyte stimulating factor to stimulate stem cells to migrate from the bone marrow to the peripheral blood, and they successfully collected stem cells from the peripheral blood. And nowadays, most of the stem cell collection is from peripheral blood, except for some indications for bone marrow transplant. Because of peripheral blood contains many of the lymphocytes, which might lead to higher risk of GVHD, graft versus host disease, in the peripheral blood. While in the bone marrow, the stem cells are lacking, they are not rich in the lymphocytes. That's why we use bone marrow stem cells for benign conditions, while we use peripheral blood stem cell collection for malignant conditions, like leukemia, because we need the effect of graft versus host disease. The peripheral blood is rich with lymphocytes, and those lymphocytes, they attack the disease. It's not only the effect of chemotherapy or radiotherapy, it's the effect of lymphocytes of the donor attacking the malignant cells of the recipient, of the patient. So we have two ways of attacking the disease, by giving high-dose radiotherapy or chemotherapy or both, and or plus the effect of the donor lymphocytes attacking the malignant cells of the recipient. That's why we use peripheral blood or peripheral stem cells for malignant conditions, and we use stem cells from the bone marrow for benign conditions. What do you know about benign conditions that are an indication for transplant? Do you know any benign condition that we use bone marrow transplant to cure?
Aplastic anemia.
Aplastic anemia, yes. Severe aplastic anemia. This is the major indication for benign condition for bone marrow transplant. We use the bone marrow stem cells. Again, thalassemia, sickle cell anemia, and metabolic diseases of the newborn, like Gaucher's disease, right? Okay, so we have many benign conditions, especially in pediatrics. We use stem cells or allogeneic bone marrow transplant for cure, because there is no cure for sickle cell anemia or thalassemia, right? So we use bone marrow transplant. Okay, what's the idea of bone marrow transplant? Does anybody know? The idea is replacing the diseased bone marrow with a new bone marrow. Just to take out the bone marrow of the patient, which is in the malignant conditions like leukemias, myelodysplastic syndrome. The stem cell is diseased, right? The leukemia cells, they are originating from the bone marrow, right? So you have to ablate the bone marrow of the patient to get rid of all the malignant cells in the bone marrow. So the idea, we give high dose of radiotherapy, total body irradiation with chemotherapy, high dose of chemotherapy, to kill all the stem cells in the bone marrow. So if you kill or ablate the whole stem cells in the bone marrow, would the patient survive? No, there is no stem cells in the bone marrow. So you need new stem cells, which are healthy stem cells. So we collect healthy stem cells from a donor. And the donor is usually a sibling with matched HLA system. So after giving the high dose of radiotherapy plus chemotherapy, we infuse the stem cells collected from a healthy donor, usually fully matched sibling, or sometimes we use unmatched, matched unrelated donor, fully matched, sometimes we use unfully matched, according to the availability of the stem cells. So after giving high dose of chemotherapy or radiotherapy or both, the patient becomes ablated and all his stem cells disappear from the bone marrow. His counts, white cell count goes down to 0. After that, we transfuse the donated stem cells through a central line. It goes to the circulation, and it has specific characteristics that migrate to the bone marrow, and it starts from there replicating and producing new stem cells and differentiating into platelets, white blood cells, and red blood cells. This is simply the idea of transplant. So high dose of chemotherapy plus minus radiotherapy, ablation of the bone marrow, and transfusing donor stem cells. This is the whole idea. This is the allogeneic transplant. About auto transplant or autologous transplant, it's the same idea. We give high dose chemotherapy. Sometimes we give high dose chemotherapy plus radiotherapy. But before giving the high dose and ablation of the bone marrow, we collect stem cells from the patient himself. We give high dose of GCSF, you know GCSF,
Stimulating factors.
that stimulates the stem cells to replicate and migrate from the bone marrow to the peripheral blood, and where it's collected, and we collect according the number of stem cells according to the body weight of the patient, and we keep it in the blood bank till after we give the high dose chemotherapy or radiotherapy or both, and then after that we reinfuse the patient's own stem cells to the circulation, and it migrates to the bone marrow, start replicating again. The idea of allogeneic transplant, why we do allogeneic transplant in certain people and autologous transplant in other patients. The idea is for malignant conditions like leukemias, the stem cell itself is the leukemia, right? While in autologous transplant, the stem cells, they are intact, they are not diseased. Like in lymphomas, Hodgkin and non-Hodgkin lymphoma. The stem cells, they are intact, but the lymph nodes or the lymphatic system, that is involved by the disease, by the malignancy. So we don't need to kill the stem cells, we just need to eradicate the disease. It's different a little bit from allogeneic, and the idea is giving the high dose of chemotherapy and radiotherapy for lymphomas is to overcome the resistance of malignant cells to the regular dose of chemotherapy. We treat Hodgkin lymphoma and non-Hodgkin lymphomas with chemotherapy plus minus radiotherapy. And in some cases, some patients, they are resistant to this regular dose of chemotherapy or radiotherapy. So we need to overcome this resistance with higher dose of chemotherapy. This higher dose of chemotherapy will ablate the bone marrow. So we cannot give higher doses of chemotherapy without storing the stem cells of the patient and then infusing the stem cells back to the same patient. This is the difference between allogeneic and autologous transplant. Anybody doesn't understand what I'm saying? Anybody understands what I'm saying?
Yes.
Not everybody, huh? Anybody has any question? Simple, right?
Yes.
Okay, in oncology, we use chemotherapy, right?
Okay.
We don't have it. We just treat malignancies, especially hematological malignancy with chemotherapy, right? Some malignancies, you cannot control the disease with just regular doses of chemotherapy. You need to give higher doses, very toxic doses of chemotherapy. And this high dose, or myeloablative dose, we call it myeloablative dose, to overcome the resistance of the malignant cells. So the bone marrow will be ablated after this high dose of chemo or radiotherapy, and it will not restart again unless you have stem cells as backup and reinfuse after giving this high dose of chemotherapy. This is the whole idea. Okay, we already talked about peripheral blood. Okay, what are the indications for bone marrow transplant?
Indications.
Yes, leukemias. It came first. Leukemias. What type of leukemia? How many types of leukemia do you know?
Acute,
Acute and
chronic, between
How
them,
many types of
MDS.
acute leukemia?
Acute,
Shajja.
Acute myeloid and acute lymphoid.
Yes, acute lymphoid leukemias and acute
Myeloid.
myeloid leukemias. How many types of acute lymphoid leukemias?
BUT?
and TL.
T and B
T and
and
B.
T leukemias. How many types of acute myeloid leukemias?
Oh.
Yes, many. Oh, they are discovering new types. According to what?
cells,
Stage of differentiations.
according to cytogenetics, they used to classify acute myeloid leukemia from N0 to N7. Okay? Now it's not valid. They still using this classification, the FAB classification, British American British classification, but now they are using cytogenetics to classify acute myeloid leukemia because they are really different types of myeloid leukemias. So certain types of leukemias, they cannot be cured with just regular doses of chemotherapy. We need higher doses of chemotherapy, which is transplant. In acute lymphoid and acute lymphoid leukemias, T or B. And nowadays, most of the bone marrow transplant doctors, they are pro-transplant for everybody who has acute lymphoid leukemia. After giving the regular doses of chemotherapy, they send him to transplant. Every patient with acute lymphoid leukemia. Some of the physicians, they say it's mandated to transplant every patient with acute lymphoid leukemia. For acute myeloid leukemia, we have certain cytogenetics with high risk of relapse, such as those with certain cytogenetics like FLT mutation, FLT mutation. Those patients, they are at high risk for relapse. And regular doses of chemotherapy will not cure. Most of them, they will relapse soon. So they are candidates for transplant from the beginning. Some myeloid leukemias, they are low risk for relapse. Like what? APL, M3, okay?
Promyelocytic leukemia.
Yes, M3. Wuxu translocation, which translocation?
15, 17.
Yes, they have very good prognosis, and they have high rate of cure. So they are not candidates for transplant from the beginning. They are cured with chemotherapy. But some types, like I said, with certain cytogenetics, they are at high risk for relapse, and from the start we plan for transplant. Okay, we have other indications for transplant, allogeneic transplant, like
Hereditary is anemia.
myelodysplastic syndrome. You know myelodysplastic syndrome, right?
Yes.
Okay. Another indication is myeloproliferative disorders. Other indication, CML. What's
Chronic myeloid leukemia.
chronic myeloid leukemia? How do we treat chronic myeloid leukemia?
One.
We treat them with targeted therapy.
Anti
Yes, imatinib.
Imatinib.
What's imatinib? Targets
APC.
what?
APL
Which
PCR.
translocation?
The 922.
Yes, what do you call this?
APL PCR. Philadelphia
BCR fusion gene.
Philadelphia chromosome, right?
Fusion gene.
This drug, it's not a chemotherapy, it's a targeted therapy. It was a revolution in treating cancer.
CML.
The
Yes.
first targeted therapy, not
chemotherapy.
chemotherapy, to treat cancer. It targets this translocation and removes this translocation from the circulation, and cells become normal. We can cure many patients with targeted therapy, imatinib, and they live normal life. Very few of them, they need transplant. In the 70s and 80s, almost probably all patients with CML, they were used to be transplanted. Now, very few cases they are transplanted. So we treat them with targeted therapy. Okay, we have other indications for transplant, autologous transplant. Solid organ malignancies, like what? This is a hematological malignancy. Yes, hematological malignancies for autologous transplant, lymphomas, mainly Hodgkin lymphoma and non-Hodgkin lymphoma. Not all non-Hodgkin lymphomas, but mainly diffuse large
Large
B-cell
B-cell
lymphoma,
lymphoma.
which are refractory to chemotherapy, regular doses of chemotherapy. We do autologous, same patient, stem cells transplant. Other solid organ autologous transplant, germ cell tumor. Testicular tumors, those who are resistant to regular doses, who relapse after regular doses of chemotherapy, they are usually treated with autologous bone marrow transplant. They used to do transplant for everything in the 80s and 90s, especially for breast cancer. And then they found it was not beneficial. There was no more benefit than just regular doses of chemotherapy. So they quit doing transplant for breast, kidney, and other solid organ like sarcomas transplant. So now we have only limited indications for bone marrow transplant, hematological malignancies, and in the solid organ transplant, only germ cell tumor malignancies, we do transplant. Otherwise, we don't. So if anybody tells you that this is a systemic disease like sarcoma or breast cancer or lung cancer or kidney cancer, you need transplant, there's no indication now in this time for bone marrow transplant. Okay, there are some benign conditions that are cured only with transplant, like we said, hematological diseases, thalassemia, sickle cell anemia, and like metabolic diseases of the pediatrics. And we have the, one of the main indications in pediatrics is neuroblastoma, and one of the main
Fanconi anemia.
congenital, yes, like Fanconi anemia, congenital disorders of hematopoiesis. These are the main indications for transplant in pediatrics.
مش الفانكوني أنيميا بتكون مشكلة ب53 ولا أنا بتهيألي؟
Okay, the idea of stem cells, the stem cells, they have certain characteristics. They can replicate and they can differentiate. Otherwise, if they cannot replicate or duplicate, they will not survive. And if they cannot differentiate, they will not produce elements of blood. This characteristic is unique for the stem cells. So we don't transplant, like some people now, they are trying to do transplant for spinal cord injuries. We don't have success stories till now because we don't know what kind of the cells or neurological cells, they don't have these characteristics of stem cells to replicate and to differentiate. So that's why we are successful in bone marrow transplant, not in other organs or cells transplant. Okay, this is the idea of stem cells, how they replicate and how they differentiate to all kinds of blood cells, mast cells, platelets, red blood cells, and dendritic cells, T and B lymphocytes. We have many stem cells. We don't use them, but types of stem cells that do replicate, like totipotent cells of fertilized oocyte, and pluripotent cells like embryonic stem cells, and the multipotent cells, which are the hematopoietic stem cells. Okay, after finding that there's a system, or the HLA system, that should be tested for every patient who is going to receive the stem cells and for every donor, and they should be matched. This is the HLA system. We have HLA A, B, and C. For siblings, we use only the A, B, and C HLA typing. Everybody has two haplotypes, one from the father and one from the mother, and siblings, they have a percentage of 25% that they have the chance of being matched. So we test the HLA, or we do HLA typing for siblings. If they are matched, we do six HLA typing. If they are matched, we say this is a fully matched donor. If it's less than 6 out of 6, we say this is unmatched related donor. For those who are unrelated donors, we test not only the HLA-A, B, and C, we test the major or the class 2 major histocompatibility complex, the HLA-DR, DQ, and the DP. So we test 12, and we say it's 12 out of 12, not like the siblings, because in unrelated donors, we have still minor incompatibilities. Despite we say this is a fully matched donor, still there are minor changes or minor incompatibilities that might cause rejection of the graft, or it might cause severe graft versus host disease, not like in siblings who are 6 out of 6 HLA matched. Is it clear or not clear? واضح ال HLA system؟ واضح؟ In siblings, we take 6 out of 6. In unrelated donors, we take 12. If we don't have 12 sometimes, and there's an emergency, like the patient has leukemia, and he has no chance to survive without transplant, we sometimes take not fully matched donor, we take 10 out of 12. If there is an emergency to do transplant. And how we do that, how we get the unrelated donors, there's a bank. There are many banks in the world, one in Europe, one in Brazil, and one in the United States. And in Jordan here, we have a contract with the European banks, and we get stem cells from there. So there are many volunteers in the world. They donate their stem cells for free, but they don't donate their time, and they're traveling for free. So you have to pay for their traveling and for their whatever they ask for. And so if somebody has, he needs to transplant, he has no sibling donor, we send his HLA typing to the bank, stem cell bank, and we do matching there. If it's matched, we take this donor, and if he agrees to donate his stem cells, we bring him and we collect his stem cells. Okay. As we said, after giving a high dose of chemotherapy plus minus radiotherapy, the patient will be prepared. We give immunosuppressants, so the patient will not reject the donor's stem cells. This is an allogeneic transplant, and after transfusing the stem cells, we continue the immunosuppressants to suppress the patient's immune system. So it will not reject the graft. And we continue immunosuppression according to sometimes we keep it for 70 days in some kind of transplant, sometimes we keep it for 6 months, and sometimes if there is signs of chronic graft versus host disease or acute graft versus host disease, we keep it for sometimes 4 years. Immunosuppression, we depend on steroids and on other immune modulating agents like cyclosporin and Prograf. There are many complications for transplant, allogeneic transplant. Autologous transplant is not that complicated. It's because it's on patient stem cells. So there is no reaction to your own stem cells, right? It's your own stem cells. It's just the high dose of chemotherapy that is toxic for the patient for every organ, while for the allogeneic transplant, it's a graft. It's a foreign body transplanted in your body, so your immune system will start attacking this foreign body, and the lymphocytes of the donor will start attacking your own cells. So that's what we call graft versus host disease. Graft versus host disease, we have two types of graft versus host disease. During the first 100 days of transplant, we call it acute graft versus host disease. If it occurs within the first 100 days, and it's usually manifested by skin rash.
Febrile reaction. Febrile syndrome.
No, not fever. There's an immune complex between the cells of the donor and the recipient. They start attacking the normal tissue. So it attacks everywhere. It attacks the skin, attacks GI tract, from the mouth down to the rectum, might cause mucositis, gastroenteritis, and it might attack the liver, increases the bilirubin and liver enzymes. We have, usually these are the manifestations of acute graft versus host disease. Chronic graft versus host disease, which occurs after 100 days usually. And the immune complex attacks everywhere. Attacks the eyes, attacks the skin, attacks the lungs, the kidneys. Any organ can be attacked by this immune complex, and it might cause organ damage or organ failure. How to treat this and to overcome this with immune suppression? Usually we start with steroids and we upgrade with other immune regulating agents like cyclosporine. Okay, this is what happens when an immune complex between the immunity of the system of the patient, of the recipient, and the donor stem cells. And we have many other complications. They are not related just to the graft itself. It's related to the high dose of radiotherapy and high dose of chemotherapy. شوفي على الواتساب يا نايم اللي جنبك والله صحينا يا the one who's next to you.
طب مصاري صعب أبو بكر.
If you are not interested, you can leave. You can leave if you are not interested. Okay. So there are many complications. They are not related directly to the graft. It's related to the high dose of chemotherapy and high dose of radiotherapy. The high dose of chemotherapy might affect any organ. Might affect the lungs, skin, kidneys, heart, GI tract, muscles. Every organ can be affected by high dose chemotherapy or radiotherapy. And there are immediate complications, and there are later or remote complications, especially like cancer. For those who are exposed to high dose of radiotherapy, they might develop skin cancer or soft tissue cancers like sarcomas. Again, leukemias and myelodysplastic syndrome that might be a complication of high dose of chemotherapy and high dose of radiotherapy. So there is a cost for transplant. It's a very toxic process, suppresses the immunity. Besides high dose chemotherapy, once the bone marrow is totally ablated, there is no immunity. So the patient is prone to any type of infection with just simple infections. Any infection can kill the patient. That's why they are kept in a certain place that is sterile, and everybody should be, or to be in contact with this patient should be always taking precautions. So they are prone to every kind or all kinds of infections, Some of the infections, they come from within the body. Some infections, they are from outside, from the environment. Especially the most serious infections, they are fungal infections and mainly Aspergillus. We all have immune system. That's why we fight simple infections like fungal infections, but patients with bone marrow ablation, they don't have immunity. They have zero immunity. So they cannot tolerate any kind of infection. They are kept on antiviral, antifungal, and antibacterial prophylaxis while they are, when they are immune compromised. Once they regain their immunity and their immune system goes back to normal, we start reducing the doses or stopping the prophylaxis. What kind of infections? We have bacterial infections, serious bacterial infections. We have pneumocystis pneumoniae. That's why we give prophylaxis for PCP, or we call it now pneumocystis jirovecii, right? And we give prophylaxis for viral infections, mainly herpes simplex virus, and we give prophylaxis for fungal infection, antifungal drugs to protect the patient and make him pass to where his immune system goes back to normal and regains its function. Okay, we already talked about infections, graft versus host disease. Okay, we have cytomegaloviral infections. Because of low immunity, we all, most of us have been exposed to CMV infection. But because of our immunity is functioning well, this infection is well suppressed by our immune system. But once the patient has or exposed to high dose of chemotherapy or radiotherapy has no immunity, all these kind of infections, they might start to reactivate. And CMV infection is one of the serious infections that might affect patients with bone marrow transplant. It's like chronic GVHD or acute GVHD. It might attack any organ. It might cause gastroenteritis, mucositis. It might be fatal. That's why we give prophylaxis, and we always measure CMV by PCR after transplant. If there's any reactivation without disease, we should start treatment. Other infections like EBV viral infection, other respiratory viruses. Mainly we have the adenoviruses. And besides, we have the viruses that might cause hemorrhagic cystitis, like JK virus. When the immune system is intact, those viruses, they don't cause any disease, but when the immunity is very low in transplant patients with all kind of infections, simple infections, they might be serious infections. Okay, as we said, all organs can be affected by the high dose of chemotherapy or by the chronic graft versus host disease, and it might get organ failure, and we should always pay attention to all organs and monitor the function of all organs. Okay, I think we finished. Any question about transplant? Okay, what are the indications for bone marrow transplant? Autologous transplant? Lymphomas. What kind of lymphomas?
Hodgkin and
Hodgkin and non-Hodgkin. Okay. Other autologous transplant for solid organs? Germ cell tumor. These are the only indications for autologous transplant. For malignant hematological conditions, leukemias mainly, myelodysplastic
MDS.
syndrome,
myeloproliferative.
myeloproliferative disorders. Okay, it's very simple, but the actual life is very tough. The patient depends totally on you. He needs total parenteral nutrition. He needs very careful observation for any signs of infection and for any early signs of acute or chronic GVHD. and he needs monitoring. For autologous transplant, we monitor the patients for 100 days. He usually kept for around 20 days in hospital, and then around the hospital for around 100 days. For allogeneic transplant, we keep them around the hospital. Inpatient for 30 days, and then 100 days very close to the hospital, and after that they need to be monitored for life. Allogeneic transplant is a job, is a full-time job for the patient because he needs to be monitored almost probably after discharge twice weekly, then once weekly, and then monthly, and probably more than that. He needs to be readmitted every time. He needs to be monitored all his life for signs of chronic GVHD. Chronic GVHD might occur anytime, even if the patient was off treatment and he's completely cured. He needs to be monitored for chronic GVHD for life. Unfortunately, not all cases of allogeneic transplant, they are successful. We have risk of relapse and failure of graft. Usually failure of graft if you collect the well-matched donor cells and adequate stem cells. Failure of a graft is probably only around 10%. But the failure rate of treatment is high. Sometimes it's for acute leukemias, the cure rate probably around 40%. For lymphomas with autologous transplant, the cure rate for Hodgkin and non-Hodgkin around 30 to 40%. So it's not always a cure or a success story. Some patients, they will relapse soon after transplant. One more thing about transplant, sometimes we use small doses of chemotherapy. We call it RIC, reduced intensity conditioning, small doses of chemotherapy. These small doses just to control the immunity of the patient, not to reject the donor's stem cells. And we depend on the stem cells of the donor to attack the disease of the patient and to kill the malignant cells. So we just give small doses of chemotherapy to suppress the immune system of the donor, of the recipient, and give the job to the donor stem cells or the immune stem cells of the donor to attack the malignant cells of the recipient. This is what we call reduced intensity conditioning. One more thing, we have the stem cells from the cord blood. Because the cord blood is rich with stem cells and they lack the lymphocytes. They don't have, still they are immune deficient, and we use them for transplant, especially in pediatric population. In adults, cord transplant, the cord or the stem cells of the cord, they are just small number of stem cells. They are inadequate for adult. Sometimes we do double cord. We take double cord, 2 cord stem cells to transplant an adult. But usually we use stem cells of the cord for pediatric population. And usually it's successful because there is low risk for graft versus host disease. Okay. Any question? Clear? Simple? So you can try it at home. Start transplanting your pets. Chronic graft versus host disease.
نفسي أسأله سؤال.
Any question?
How long can we keep the cord blood?
For life. We have now banks that they are storing the cord blood for everybody. You can donate your own. If you have a baby in the future, you can get his cord blood and you can store it in the blood bank or in the stem cell bank and keep it for your baby for his life. And sometimes people, they donate the cord stem cells because, you know, the placenta and the cord, they are rich with stem cells, and what they usually do with the stem cells, they just burn it. right? So now they are putting it in the bag. Other questions? Right.
Can we culture the stem cells from the core?
Okay, that's what they try to do, because stem cells of the core, they are inadequate. So they try to replicate the stem cell. This is a good question. That's what they are trying to do, because we don't have enough stem cells in the core. So they try to duplicate or replicate the stem cells. But till now, they are not really successful. Other questions? Okay, where do we have stem cells still, other than the bone marrow and the placenta? Do you have stem cells anywhere in your body? Where? الأسنان اللبنية، تعرفوا الأسنان اللبنية؟ أسنان الأطفال, they have stem cells. There is now a ban collecting anybody's who has baby teeth. They have stem cells. Okay. No more questions? Thank you, everybody.